Well, everyone, it's 7:05, so I think we should begin this webinar on financing healthcare for all. I'm Karen Christensen, Chair of the Mid-Valley Healthcare Advocates located here in Corvallis. Our sponsors tonight include Mid-Valley and Healthcare for All Oregon and the League of Women Voters. And the League deserves a special thanks for hosting this on their webinar platform. Our speakers tonight will be Ed Junkins as moderator, Warren George, Doug Boysen, and Marty Wilde, who'll be joining us a little bit later. So without any further introductions, I'll turn it over to Dr. Junkins to get the webinar going. Thank you.
Thank you, Karen, and thank you to the sponsors of this important conversation. Those of us who have spent a fair amount of time working on access to healthcare find that the most important tool that we have is the dialogue and the engagement of our community members. So it's this kind of interaction which really is the life source of the work the task force is doing on universal healthcare. And so I appreciate the opportunity. Again, I'm Ed Junkins. I serve as the vice chair to the 770 Task Force on Universal Health here in Oregon. We've been doing some terrific work over the past calendar year and have had the opportunity to work with several of the people who you're going to see on our panel tonight. One of our speakers tonight, who I'm thrilled to introduce, is a friend of mine and a colleague and a peer in terms of his enthusiasm for healthcare. But he has no equal with regards to his knowledge of the financing and the numbers around healthcare and how to make that happen as far as universal access, single payer, single pool. Warren George is a true gem in our community. You might have seen him out in front of you playing his upright bass, or you might have seen him talking about his numbers, but he is really an asset to our community. And let me turn things over to Warren George to educate us about some of the numbers. Thank you.
Okay, thanks, Ed. That was more than sufficient. Thank you very much. In my main career, I was director of primary operations and plant manager for Oregon Metallurgical Corporation in Albany. I've been billed in this forum as providing a business perspective, but I don't look at my business perspective as being different from my perspective as a community member. I find it a little bit difficult to do. I like live audiences, so I'm showing you a picture of what I'm actually is pasted on the wall in front of me, grandchildren, and that's actually what this is all about, is if we do things successfully, we will make things better for our grandchildren. My presentation will follow this outline. Why consider changing the system? It's not surprising, the cost. Why does healthcare cost so much in the US? How could universal care help? How could the financial transition to universal care work? In terms of real dollars, we are paying more than 10 times as much for healthcare per person as we did in 1960. Are we getting 10 times the value? I don't know, but I do know that in grade school in 1956, I shouldn't admit that, I learned that the three human essentials are food, clothing, and shelter. But literally out of nowhere has come a fourth essential, which is now dominating. The per capita cost of care hasn't always been double the average of other industrialized countries. It's gotten there gradually, and the effects are significant. The US is #1 in poverty rates, rates of poor health, rates of suicide from desperation over the cost of healthcare, #1 in loss of jobs for lower middle income workers, as employers have to include our high cost of healthcare in decisions of whether to employ, automate, outsource, or eliminate jobs. The rising cost of healthcare detracts from everything else we do. Every new dollar going into healthcare is a dollar that used to go somewhere else. As individuals and communities, we are gradually losing our choice to spend money on other things of value. What are we currently doing about the problem of high cost? We're using the uniquely American strategy of trying to outspend it. The ACA successfully serves more people, but at an even higher cost per person. The ACA will continue to increase how much more we pay than other countries. Where does the extra $5,000 per person go compared to other countries? Not many researchers have taken on this full question, but an article published in JAMA by Dr. Irene Papanikolaou of the London School of Economics offers some specific insight. Dr. Papanikolaou and her co-authors compared large medical data sets between countries and concluded that our relative response to specific diseases is actually about the same as other countries. Cost difference isn't in what we do, it is in what we pay for substantially the same services. The article identifies 3 areas which account for almost all of the $5,000 extra. Using industry data, it is possible to estimate the cost of various components of our healthcare delivery system. About 70 to 72% of the costs of healthcare is labor. Drugs and other supplies are 15 to 20%. Net cost of insurance, also known as financial administration, is reported to cost about 12%. Facilities, utilities, liability insurance, and profit are also shown here with an estimate of their contribution to the total cost. This is based on an aggregate of all types of services. Some individual service groups will be higher or lower in their specific distribution of cost. With Dr. Papanikolaou's help, our US expenditures can be compared to the average of other countries. While there are some significant percentage differences in the amount paid for facilities, utilities, liability insurance, and profit, these are smaller components of the total cost. Getting into the 3 major categories identified by Dr. Papanikolaou, we spend on the order of 10 times as much on financial administration. We spend up to 2.5 times as much for the same drugs and supplies that other countries purchase for less. And because labor is such a large category, even a smaller percentage difference in wages and salaries eats up a lot of money. According to Dr. Papanikolaou's study, specialists make 3 to 5 times as much in the US. Primary care physicians make about double. Nurses, technicians, and therapists make 15 to 50% more than in other countries. As Dr. Papanikolaou points out, this higher wage rate for professionals in the US is not unique to medicine. It is also true of other specialties like engineering. Simply put, a problem that we have in the US is that we have a wider spread between the incomes of those who provide medical services and the incomes of average people who need to purchase those services. By subtracting the columns in the previous graph, here is a reasonable estimate of where our $5,000 per person extra money goes compared to other countries. This shows financial administration as being a little lower than the other 2, but this graph does not include the full amount of time spent on billing and insurance paperwork by medical providers under the labor category. It would be best to consider these 3 main causes of higher cost in the US as being approximately equal in magnitude. Any attempt to bring our costs more in line with other countries will need to be focused on these 3 areas. How do we address those costs? Let's start by considering some history. In 1960, most medical care was paid for out of pocket, and medical insurance was only for catastrophic coverage. The shift since then has been dramatic. As the cost of care has risen, Medicare and Medicaid programs have been made necessary due to the increasing cost of people who could not afford private insurance. The top three sources of Oregon's approximately $40 billion in medical expenses are now private insurance, Medicare, and Medicaid, two of which did not exist in 1960. Medicare and Medicaid have not effectively controlled total costs, only shifted it. Here is a schematic demonstrating that the need for healthcare service increases as we age. Prior to Medicare, individual cost and insurance policies were getting very expensive for older people based on the amount of care they use. Medicare Act of 1965 addressed the high cost of older people by transferring a significant portion of that cost onto people under age 65 in the form of Medicare taxes. Because the cost of providing healthcare has risen faster than Medicare taxes or Medicare premiums, seniors are now paying less and less of their actual costs, and more of the cost is coming out of the general fund budget, paid mostly by people during their working years. Medicare payroll taxes and Medicare premiums now only account for about half of the total cost of Medicare services. Of the 6 ways in which we fund healthcare, the rise of Medicare and Medicaid funding through general taxes has made income taxes the fastest rising source of healthcare dollars. Just as Medicare began by shifting cost onto people under age 65, the continuing growth in Medicare and Medicaid has resulted in shifting more of the cost onto higher earners through these income taxes. Dividing Oregon taxpayers into 5 quintiles or equal sized groups, with the top quintile having an income of more than just over $100,000, shows that the current cost of healthcare is being significantly carried by the top 20% of earners. This trend is accelerating. Our ability to continuously shift the cost onto younger people and onto people with higher incomes has allowed the US to avoid doing anything serious about the basic problem, the unsustainable rise in the cost itself. This is what makes universal care based on a single risk pool, single payer system different from the other things that we've already tried. It is based on reducing the cost of healthcare while maintaining our high quality of care. Imagine walking into a hospital or major clinic and never being asked to fill out an insurance form, ever seeing a bill because there is no bill. Hospital or major clinic gets an annual budget to take care of its patients. No bills, no cash registers, no co-pays, no deductibles, and in fact, no billing department. Not only would insurance costs be significantly reduced, the part of provider labor that is currently being spent on payment paperwork would go down. By sharply reducing individual billing costs in this way, we could save about $1,200 per person per year, possibly much more as the full efficiencies come into play. And if a single payer system could purchase drugs and other supplies at the same price as the VA in other countries, we could save an additional $1,200 per person for a total of $2,400 per person, or over $7,000 savings for a 3-person household per year. Acting as a community, we could spend, say, $1,400 of our individual savings on providing full coverage for every person in the state and still have $1,000 per person left over. This opportunity is compelling from both a financial and a humanitarian standpoint. What would it take to create a universal care system in Oregon? We'd have to change some thinking about assigning costs to specific patients. We'd have some community planning to do, and we would need to have public acceptance of a different way to fund healthcare. In Oregon, we pay about $40 billion in total healthcare costs. About half of that comes from private insurance and other direct private payments, and about half comes from Medicare, Medicaid, and other government programs. A universal care single payer system would presumably require that both these systems funnel their payments into one combined medical disbursement program. On the public side, there is a bill currently being introduced in Congress to enable the federal government to pay into a state-based universal care program out of Medicare and Medicaid and other programs. On the private side, it is most commonly proposed that the easiest way to direct this revenue into a single payer system is to replace current premiums and out-of-pocket with a state healthcare tax. By combining the public and private sources into one universal funding system, we could provide care to everyone, save a significant amount of money in the process, while dramatically reducing complexity. It really is a bold idea. When savings are taken into account, we would only need to convert, say, 16 or 18 billion to replace 20 billion in current private spending. Most people have a hard time envisioning what $16 billion looks like. So consider that the entire amount of income tax collected to run the state of Oregon in 2015 was just over 7 billion. This means that an Oregon healthcare tax would need to be 2 to 3 times the size of the income tax that funds our state government. Would voters ever go for a tax that large? One of the key questions asked in the Elway poll of Oregon voters in 2019 was this: would you be inclined to vote for a ballot measure that established full lifetime health care, including vision, dental, and hearing, for every person in Oregon, with all medical expenses paid by a state agency, meaning no private insurance premiums, co-pays, or deductibles, and funded by a new state healthcare tax 2 to 3 times as much as Oregon's income tax funded government? The rather surprising poll result is that 62% said they would definitely or probably vote in favor. Business owners and self-employed, sometimes assumed to oppose such a program, polled 60% in favor. Majority support for universal health care funded by a state healthcare tax held across all 5 of Oregon's congressional districts. District 2, which voted for Donald Trump almost 2 to 1 over Hillary Clinton and Joe Biden, polled almost as high as other districts for a large healthcare tax to provide healthcare to everyone. And somewhat surprisingly, while the Democratic Party regards universal care as its own issue, the majority of favorable responses in the poll came from unaffiliated Republican and third-party voters. One thing the poll did show is that support for universal care tax in Oregon is very age dependent. There was no net support above age 50, possibly due to worries that a new program might affect Medicare. But similar polls to this had shown as many as 80% of seniors to be opposed in years past, so opinions may be shifting. How could an Oregon healthcare tax be designed? It would need to be of sufficient size, would need to be relatively stable in economic ups and downs. Taxes can generally be divided into 3 categories: taxes on income, such as income taxes and payroll taxes; taxes on transactions, such as sales taxes, or taxes on wealth, such as property taxes. There are other specific taxes, such as excise taxes on beer, wine, marijuana, etc., but these are all far too small to be considered. Sales tax would probably make good economic sense, but has been unpopular with Oregon voters. Many people argue that sales taxes can be regressive. Wealth taxes are difficult to design on a state basis. Since much wealth is tied up in property, Oregon's constitutional limits on property taxes largely rules out wealth tax in Oregon. For these reasons, most attention, but not all, for funding universal care in Oregon has been given to a tax based on income. Looking at the breakdown of all taxable income in Oregon, this happens to be from the year 2015, wages typically constitute over 70% of Oregon's total income, with the remainder made up of retirement income, regular business income, C corporation business income, capital gains, and dividends and interest. Right away, you can see from the graph that raising $16 billion by taxing $7 billion in capital gains is not inadequate to raise the money. Besides the size of the tax base, stability is very important. This graph shows what happened to various types of income in the Great Recession beginning in 2008. Capital gains fell 72% and took more than 5 years to recover. Corporate income fell 44%, dividends and interest fell 43%, income of the top 1% fell 34%, while total wage income only fell 4% and recovered more quickly than other sources. Retirement income actually grew, possibly because of people retiring early due to job loss. A tax principle featured in T.R. Reid's book, A Fine Mess, is the principle of BBLR, or bubbler, which stands for broad-based low rate. Its concept is that you find something to tax that applies to virtually everyone, like household income, and you don't allow hardly any exclusions or deductions or credits. The key part of the bubbler principle is to tax all income at the same rate, thereby minimizing the ability to game the system. Here is an interactive calculator developed for Oregon, which allows people to experiment with different combinations of taxes just by pressing a few arrows. Send me an email. I will send you the spreadsheet. You can have fun designing all the taxes you want. Shown here is one example that raises $16 billion by spreading the cost over a collection of revenue sources. A $100 per month premium collected for persons above the poverty level, a 9.8% tax collected both on payroll wages and also on other sources of personal and business income, a 2% extra tax on income above the threshold of the top 1%, a 2% extra tax on income of Class C corporations operating in Oregon. One thing to remember, though, is instead of just to start designing a tax, we should remember that we already have a funding means that raises more than enough money. So rather than starting fresh, designing a new tax, a more functional approach is to start with the current system and then to consider who, if anyone, should pay less or pay more in the transition to a new system. Let's take age as an example. Here is a schematic of the current system. People under age 65 pay premiums and other expenses based on their age rating. I can relate to this graph by comparing two of my friends. One, age 23, is paying about $3,000 for medical coverage. Another, age 63, just quoted $17,000 per year for an insurance policy. The one paying $17,000 isn't necessarily being overcharged. That is pretty close to the average cost of medical services provided to someone of that age. By the way, people over age 65 currently pay for a subsidized rate based in part on having paid Medicare taxes prior to retirement. So how would we transition this cost to universal care? This goes back to the discussion of what is the primary purpose of universal care. Is the primary goal to renegotiate payment in a way that changes who pays? This is the same strategy that was used in the past for Medicare and Medicaid. Or is the primary goal of universal care to reduce the cost of healthcare for everyone, with part of the savings going to pay for better care for people who currently don't have adequate coverage? If we focus on evening out the effect of people paying at different rates in order to change who pays, Average cost for my 63-year-old friend will be a cut in about a half, while cost will more than double for my 23-year-old friend. Charging everyone the same sounds nice in concept, but it will set up a fight. Of course, it would be nice for the 63-year-old not to have to pay so much, but for the 23-year-old just starting out and raising children, an extra $5,000 per year could be arguably devastating. The 63-year-old, after all, got through their 20s paying comparatively almost nothing for health care, and that's perhaps why they own a house and have other savings. Adding to this argument is the question of seniors. Depending on their income, seniors might be asked to carry more of the community costs. Some of this increased cost could be offset by new dental hearing benefits, as well as no longer needing to buy supplemental policies. On the other hand, if the goal is to save everybody money, we don't need to spend time arguing about the transitional shift. We can just design the new system to look a lot like the old system, but with everybody paying less than they do now. And hopefully continuing to pay less as more cost savings from a universal system come into play. Likewise, consider the transitional effects based on income. If we want to reduce the cost for everyone, then these bars showing the current system just get uniformly shorter. On the other hand, there are voices demanding further cost shifting according to income. One of the main recommendations being considered by the task force is that the current private premiums, shown here in blue, should be replaced with a progressive income tax, which has a different distribution. The effect of that change is shown here with costs being cut for the first 4 quintiles and the cost burden on the top quintile rising to 75%. There is a question whether this is reasonable or even possible. Many people would strongly object to such a dramatic cost shift, which would be the largest ever contemplated in the United States. For anyone who believes that the transitional shift should be kept small, designing this way will be politically difficult. Groups will be fighting very hard to make their case that they deserve more of the benefits and less of the cost. Some groups will use their muscle to say that they will not support universal care unless they get special concessions. This is where any design groups needs to choose some principles and be prepared to stick with them. Designing a funding system for universal care breaks down to a few decisions. Do you want to concentrate on cost savings or concentrate on cost shifting? Do you want a broad-based low-rate tax, or do you want a high-rate focus tax? Do you want to continue focusing on employment-based healthcare, or do you want to focus on moving healthcare to income and profit? Is the goal to make a bold statement by instituting big changes, or do you want it to feel just about the same, except it may be just changing where you send your check? Is it better to have sudden changes and get over with it, or to set a path of gradual changes? Finally, in making decisions, the bottom line is that equity is a natural part of a well-planned universal care system and must be protected. Nobody likes designing taxes. I will close with an old quip that the only fair tax is one which is paid by people we don't know personally, probably wouldn't like anyway. But in considering healthcare funding, we need to balance that with the kind of thinking that is the basic fact that there is nobody here but us. We will either provide care for our communities or we will not. The rising cost of healthcare in the US is economically damaged and unsustainable. If people want quality care with full access at a more affordable cost, people will need to tolerate some degree of change. The Elway poll that shows that Oregon voters in general are probably ahead of the political system in their willingness to consider changing to a universal care system. Thank you. Here is my email address. I do welcome correspondence. I have made the complete Elway poll report available at variedstrengths.com. Thank you.
Thank you, Warren. I'd like to go right into questions. We do have questions. However, I think we're going to save our questions until after our speakers. We've gotten a number of questions that are starting to come in, so it might be worth your taking a peek at the website, the Google Share document, so you can start to look at those questions. Thank you again, Warren, for I've seen that several times, and every time I learn something. It's my pleasure and honor to introduce Representative Marty Wilde. Representative Wilde is from District 11, which is the Central Lane and I think Lynn counties, kind of that general area. He is a member of the Senate Bill 770 task force, has done lots of work in this general area, and we appreciate the time he has squeezed out of his busy schedule as we're bringing the session to a close. Thank you. Let me turn it over to Representative Wilde.
Well, thank you very much, Ed.
You're welcome.
I'll start off with a quote from a guy named Russell Long, who was a senator from the South, and he said, "Don't tax you, don't tax me, tax the man behind the tree." And all these conversations around financing, sort of start with the premise that, well, gee, nobody really wants to pay for this. But we know that the sort of what we've ended up with is something of a tragedy of the commons, right? The fragmented nature imposes costs, and those costs are unpredictable and unstable, and that really is to everyone's detriment. And so that's why we're believers in this cause. Just to repeat what was just presented, you've got to be thoughtful, and I start with the premise of, well, who's already paying? We have a healthcare system. It's not great in some ways. It's good in others. There's three basic sources. Government pays for some, you and I pay for some, and businesses pay for some. And so when we look at moving to a new system, how should that change? What would the taxation structure look like that? I would say, I don't disagree. The revenue estimates are somewhere between 15 and 20 billion, depending on who you talk to and what you want to include. Sales tax, payroll tax, income tax, all on the table. Corporate tax was not really considered. Wealth tax was talked about. It's kind of tricky. And there's some unresolved constitutional questions about what we call money in motion versus money at rest. It is somewhat difficult to tax money that is not in motion. When it is moving from one source to another, it's a little easier to tax with a little fewer legal issues. So, task force is working with data to get more data and partners and working out more accurate cost predictions. The task force adopted the PEB should remain the basis for the plan benefit package. And they're looking at a lot of different ones. I am not going to go on for very long because, quite honestly, with the session, I have not been in a lot of meetings lately. And I do send staff, and I do try to catch up. I would say, when we think about the way I approach it is this, that we're trying to reduce. Sorry, excuse my cat. We're trying to reduce costs and increase stability. We all might want to shift responsibility one way or another, but I kind of start from the premise of, we're probably not going to make large scale shifts in that. So we are largely dealing with concepts that would either tax you and I, people, or corporations, usually in their role as employers. We already do tax, do payroll taxes, and payroll taxes are a predictable way for businesses to do that. One of the things we hear often from businesses that are multinationals is we really like it in Germany or pick your developed country because we just know how much it costs, right? It's a payroll tax type system or some other system that says you employ somebody, you pay this much. It's very straightforward. Whereas because the system is administered by businesses, it's unstable and the costs are very variable. So That being said, people are going to pay something. I think, again, people prefer predictability. They will accept taxation as long as it's, reasonable and it's gives, saves them from something else. So, and they will pay to avoid those sorts of price shocks, right? Medicare isn't free, but Medicare, because you're generally only responsible for 20% of the cost, those shocks are 1/5 of what they would be if you were, uninsured. And so that's basically what you're paying for, is the sort of predictability of that a little more. So I've kind of assumed that it'll be some combination of individual taxes, which could be sales taxes, could be income taxes. Keep in mind, when you have a sales tax, people pay about 2/3 and businesses pay about 1/3. A payroll tax, it would be business side. Economists will say it doesn't really matter whether it shows up as the business's expense or your expense. It's all part of the cost of employment. It doesn't necessarily feel that way when you're receiving the paycheck, but I would assume it would be employer side. And there probably would be an income tax piece of it. The challenge, as was just mentioned by Mr. Warren, is income taxes, while they are the most progressive, they are also the most variable. So, we can make a very progressive income tax scheme, and then we can get hit with it pretty hard when things go south. That makes it very difficult to keep the system going. So those are really how I approach the issue, and how I've seen the group approach the issue is, who's paying now? How can we make it, cheaper and more stable for everybody? And then, how do we transition from A to B, from what we're doing now to some future plan as well? And honestly, the single payer system really is the most stable. If you allow opt-outs, if you like, well, I want to opt out and do private insurance, you just end up with a system where you don't recognize the same benefits and the same stability, and you just end up with a system that doesn't work as well. But it's a hard transition to make. So I'd just like to thank everyone for the work, and thank you for the time.
Thank you, Representative Wilde. A couple of points I just wanted to echo back. We have we've been doing lots of work at the 770 task force. We meet every month. We've also had technical advisory groups meeting once a month, including the finance and revenue group, as you know. They just reported out to the task force, and the task force accepted it, in some cases with reservations. But the plan, as you actually just iterated, would include two options for revenue. The first would be sales tax, payroll tax, and income tax in some, to some level. And plan B would be minus the sales tax part of that. But in each case, there are different strata of what sales tax and income tax would look like. So that's kind of where the task force landed. And as you mentioned, benefits would look like PEB, with some discussions around relaxation of the limits or changing limits. So there is the attempt to augment the benefits that even PEB offers. But lots of work to be done, as much to say, please tune in. If you care about what we're talking about tonight, please tune in and send us your ideas or your opinions about what the task force is doing. The questions are coming in, and they're terrific questions. Representative Wilde, if you get the chance, you may want to peek at the Google Doc. If you don't know what that is, if you look I bet one of our moderators can help you get the link so that you can look at the questions in the chat. Otherwise, I'm going to come back once I introduce the last speaker, and we're going to start talking about the questions from our audience. Okay. Let me transition to my friend and to another community gem, Mr. Doug Boysen. As we all know, Doug is at the Samaritan Health Services helm, has done a fantastic job in steering that organization for our community through this pandemic, really doing some terrific work, oftentimes in communication with the city, with the county, because we really have to get this right. I happen to know that Doug Boysen has a lot of interest in this conversation. I've had conversations with them about this. So I would like to quickly turn things over to my friend, Doug Boysen.
Thank you, Ed. And it's a pleasure to be here tonight. Representative Wilde and Warren, I really appreciated listening to you. I think a lot of good thoughts there. And actually, I'm not going to say anything that I think opposes or contradicts, but I am going to maybe focus on a couple things a little bit differently. But I'll start off by saying, I work for Samaritan Health Services. Samaritan is a nonprofit healthcare organization. We take care of everyone and treat everyone regardless of type of insurance or no insurance or ability to pay at all. We are not an advocacy organization. In fact, we are a tax-exempt charitable organization, and we actually are restricted in some ways in what we can do from an advocacy perspective. So I come here tonight really not advocating for one thing or another, but to just kind of add to the conversation. Around the costs, I will say I kind of like to look at or think of the costs in two categories of healthcare. One is what I think of as a unit cost, and the other is the aggregate cost of healthcare. And on the unit cost of healthcare, I look at that more like, what does it cost a provider or a hospital to provide a discrete individual service, right? So what for every service we do, what does that cost? And then the aggregate cost is how much in total does a community, a county, or state, or a country pay for healthcare? And I think if you want to reduce either one of those, it probably is a little bit different strategy. On the unit cost, to decrease that, that's largely labor is what we can control. And I think Warren mentioned that about generally with hospitals, 50 to 70% of our costs are labor. Now, some of that's actually clinicians, some of that's billing, and as Warren mentioned, some of that could be a lot simpler than it is right now. There's no question about that. The interesting thing, though, about unit costs and the price of healthcare is that being on the delivery side, being in the healthcare system, we have little control over how much we get paid for most people that we treat. We get paid generally regardless of what it does cost, and we really don't have a say in how much we get paid. And the reason I say that is within Samaritan, 50% of the patients that we see are Medicare patients. So, regardless if we bill $1,000 or $100, it doesn't matter. Medicare is going to pay us according to the CMS Medicare schedule. It doesn't matter. And then the other 20% of patients that we see are Medicaid patients, and generally Medicaid has its own fee schedule as well. And then we have Indian Health Services, the VA, and workers' comp all have their own fee schedules. And that is about 75% of the people that we see at Samaritan. So we get paid whatever their fee schedules are. And then there's employer-based care and individual care. And then that's where, the pricing does become, more in what we're actually charging at that point in time. On the aggregate costs, I think that's where the big opportunity is. I mean, I think there's opportunities in both, but I think on the aggregate costs, looking at the total amount of money that a community or county or state or country spend on healthcare is where we could see a big decrease in costs. And then you start looking at population health and coordinating care better and more prevention. And I think all of that can pay back big dividends. I guess this is where I would maybe deviate a little bit from Warren and not disagreeing with him, but maybe a little bit different focus in that. Some people often ask me, what do you think about a single payer system? And I say, well, I'm actually less concerned about who's paying us and whether it's one or whether it's many. I'm real concerned about how we're getting paid. And I think traditionally we've been stuck in a fee-for-service environment in healthcare. And what that means is every little service we provide, we get reimbursed X amount of money. I think we need to move more to a population health type reimbursement. And I say that because if we're going to be successful at lowering the aggregate cost of healthcare, I think we need to retool our focus more on community health and prevention. And an example that I always think of, we have a patient in our hospital, our Good Sam Hospital in Corvallis, and I'm just hypothetical, with congestive heart failure. I'm confident that we are going to throw some of the best medicine possible in the world at that patient. We are going to have great doctors. We're going to have great technology. We're going to have great medicine. we're going to have great nurses, we're going to have great staff. We are going to throw everything. And every little piece of that, from the labs to the inpatient bed, we're going to build that fee for service, right? And then I have this image in my mind of Research Stadium, and that's the OSU football stadium, with 30,000 people sitting over there that may be obese, may have early stage diabetes, may be using tobacco, may be using drugs, all potentially on their way to congestive heart failure. But our system, there is no incentive to be out there working with those thousands of people to prevent them from getting to congestive heart failure. And I think that's a failing. I think when we're focused just on these specific reimbursable events rather than community health, we're not putting our resources in the right places to truly make a difference. I think the other thing is, under fee for service, it's really complex. And if you look at how we bill Medicare right now, there are literally 70,000 different codes that our physicians and our coders need to choose from when billing for services. And those are everything from being struck by an orca, that is a code, to being struck by a turtle, to running into a lamppost. And this is my favorite, problems with in-laws. I mean, those are all different codes that are part of that fee for service world. And again, I think we need to simplify that, and we need to focus more on community health and these individual reimbursable events. And then I will say too, if we are going to have a single payer, I hope that the reimbursement can change to a population health reimbursement. And then the other thing I would say, if we're going to have it on the state level or federal level, I hope that the resources and money can get pushed out to more of a regional perspective, or more at the local level, to then decide how best to use that money and invest it for community health. I'm a big proponent of what the state of Oregon has done through the CCOs and John Kitzhopper's vision. I think by pushing that Medicaid money to the 15 regional CCOs, so then those CCOs can decide what is the best way to invest those resources to really get the biggest return on community health that we can. I think that goes a long ways, because I do fundamentally believe healthcare is local, and every individual community probably has their unique healthcare needs. An example of that I would give, of maybe a pain point with not having it local, is we made the decision in Lebanon to construct, over the last year, inpatient alcohol and drug addiction program, rehab program in Lebanon. It's inpatient. It's the only one like that in the 3-county area. Our mission is building healthier communities together, and we felt like addiction was standing in the way of that. So we felt like we needed to step into that. According to our data, oh, and by the way, Oregon has one of the unfortunately highest addiction rates in the country, and Oregon has the fewest treatment centers. It's towards the bottom of the amount of treatment centers per population in the country. So we don't have a good ratio there. So we felt like we needed to move forward with that. When we looked at the data about how many beds we felt like we could fill for our 3-county area, and this facility in Lebanon really does serve our 3-county area, we felt like we could probably have 25 to 30 beds there. Unfortunately, there was a Medicare law passed in 1965 that if you have more than 16 beds in a residential treatment facility, the federal government or the state government won't pay you for any services. So we could only go up to 16 beds at our Lebanon facility, otherwise we wouldn't get paid. And I think that's just an example. And I say that not blaming Medicare or anything, but I just think that's an example of when all the resources are kept centrally somewhere away from here, and not an understanding of the unique issues in that local market. Sometimes there's not flexibility and there's not creativity allowed to really put those resources in the places that I think would matter the most. So I really believe that money needs to get more local. The last thing I'll mention is Warren mentioned, I think one of the things to think about is sudden change versus gradual change. And it reminded me of a speaker that I saw here in the last 6 months, and that was Atul Gawande. And I don't know if any of you have heard of him. He's a surgeon, author. He's written a couple books, Better and the Checklist Manifesto, which I think are fantastic books. And I think he's probably one of the best thinkers in healthcare reform in the country right now. He was hired by this company called Haven about 1.5 years ago, 2 years ago. And it was a joint venture by Berkshire Hathaway and Amazon and JP Morgan and a bunch of large companies with the sole purpose of disrupting healthcare and essentially bringing the price down for employers. And Atul eventually left that job, and that venture eventually ended up failing. And when I listened to him, one of his thoughts were complete transformation of healthcare is extremely difficult. It's really large, it's really long, it's really complex. There's a lot of money involved. There's a lot of stakeholders involved. And what he's come to realize is that rather than a immediate transformation, we do need to think about it in incremental stages. You know, how can we have a vision and how can we incrementally get there over the years? And I'm not saying whether he's right or wrong, but it did resonate with me because here's what I think the Affordable Care Act and what on the federal side and with the Medicaid expansion, the CCOs on the state side are great. I think they were a great step forward. Are they perfect? Did they solve all our problems? Absolutely not. But we have some good foundation there that I think we need to think twice before we just scrap all that and we try something completely different, because I think we can continue to fine tune those over time to come up with a system that's better for everyone ultimately. So those are just my thoughts. I do want to thank you all for being on the call, and I want to thank you all for your passion and support of healthier communities.
Thank you very much, Doug. You know, and again, many thanks to Warren George, Representative Marty Wilde, and Doug Boysen from Samaritan Health. We've got lots of questions in the chat, and I wanted to jump to those questions. And you know, I wanted to say, by the way, in reflection to what Doug Boysen just said, that the task force is really looking at many of the things, if not most of the things that Doug Boysen just said. You know, we are looking at fee-for-service. We're looking at, you know, benefits such as social determinants of health, some of this upstream stuff that looks at community health. How do we do that? So much of that stuff is on the table. We haven't talked about ORCAs. We haven't talked about the effect of that on healthcare. So that's a new one. I'll bring that back to the task force. And we have talked about mental health and substance abuse and addiction, you know, quite a bit. So with this, I'm gonna turn to the questions, and many thanks to the group behind the scenes that are taking the questions and organizing them for us. And I first just want to clarify, I used the term PEB earlier. PEB is the Public Employee Benefits Board. It's essentially the benefits package that public employees get in the state of Oregon. There are different kinds of benefits that a state employee might get. It's different, I believe, for the for example, a city employee versus a school district employee. But nonetheless, these are two benefit plans that we looked at very carefully and very closely. So that's what PEB means. And I also wanted to clarify that Senator Marty Wilde is a Oregon representative from the local, you know, sort of Lynn County, Central Lane area. So he's local, and he does his work in Salem and is not at the congressional level. So those are the speakers who are before you. I would like to start with we have several questions from one attendant who I'm going to read. I'm going to read one, and I'm going to just ask for whoever to respond. And if I don't get a response from one of the three of you, then maybe I'll call on you. But so here we go. And the question reads this: there seems to be little doubt that the wealth of our nation rests within a specific sector of society, so corporations and the 1%, in quotes. Do you believe that reversing the decades of adoption of corporate tax codes that have benefited the minority in our society would add a significant amount of revenue to the U.S. Treasury? And if so, do you believe that a portion of those new revenues should be dedicated to delivering health care to the population or to a broader support of federal programs? So Representative Wilde, I think you had mentioned something about the corporate tax. Did you want to address that question?
That's a tough one.
It's a very broad question.
Thanks for giving it to him.
Yeah. Yeah. My preferred way of addressing corporate taxes is actually less about raising rates and more about eliminating some of those deductions I think they were concerned about. That's for the very practical reason that if you raise a rate, it takes a 3/5 vote in both chambers of the legislature in Oregon. But removing a deduction after a 2018 court decision just requires a simple majority vote. So it turns out simplicity has a virtue in terms of our electoral and our count as well. The challenge is it's actually a fairly small piece of state income in the big picture. It doesn't have the same broad base that Mr. George was talking about. So that becomes the challenge is, if the corporate income taxes or corporate profit taxes is really what you're talking about here. You'd have to do several multiples to get a meaningful amount of money, which I think people would probably object to. The other problem I would say is fairly technical, and that is because we're tied to the federal tax system. And so whenever they change anything, it happens automatically to us unless we take an affirmative step to disengage. So that's in the Oregon Constitution. And it plays Mary Hobb with all of our plans because we'll be moving along in a particular direction, and then the federal government will decide they want to change something, and then we have to take an affirmative step, which we can do, and it only takes a simple majority vote, but it's very difficult because the federal government legislature is there all the time, and we're only there. I mean, we're there every year, but the even year session is only 5 weeks long, and it's very hard to get anything done. So, long story short is I'm all about reducing the number of deductions. The problem is you don't end up getting a lot of money out of it. I think it's worth doing for other reasons, but it's not really a very practical funding source for all that. I'm in favor of doing it.
Yeah, go ahead, Warren.
Yeah. I would just add to that, that when you look at there's two things to look at. There is income and there is wealth. When you look at income, the income of the 1%ers, the marginal income above the 1% level is only about 11% of total income. So you're really not going to raise that much money that way. And when you look at wealth, I see the critical thing that's happening in the United States to be ownership. To me, the tragedy isn't necessarily as much that income is concentrated, its ownership is concentrated. And I would love to see opportunities to widen out ownership so that more people have stock in the enterprises of the United States. To me, the far bigger problem, I spend very little time worrying about the incremental gains of the top people. And I am truly alarmed by the reduction in income of the bottom 40%, who've lost about a third of their incomes in basically 25 years. And this is a really serious question of what are we going to do about this problem if we're moving from an inherently participative economy, say of the 1950s, to an inherently non-participative economy where not everybody can participate. We have a real problem to solve. And it's actually, in my opinion, it's not really related to corporations or the 1%ers. It's a more serious fundamental problem of our economy.
Thank you, Warren. I'm going to move on to another question. This one may be more straightforward. According to the AP, the average health insurance CEO makes $14.5 million per year. By moving just one CEO and administration, how much lower administrative salaries and much lower, wouldn't there be a tremendous savings in dollars? So this is, yeah, go ahead, Warren. I know that you had a.
Yeah. When you look at the total insurance company CEO pay, it amounts to about 55 million. You can say that's obscene. You can say anything about it that you want. But the fact is, you divide that $55 million by $3.8 trillion, and you see that that CEO pay is 17 cents of your $11,000 per year. So it is an aggravation. I deny it. But if you say we're going to, I object to using that as a reason for change, because if you try to fix it by fixing that problem, you're not going to save any money at all. You could pay them nothing, and you wouldn't notice the difference. Thank you.
And just for the record, I'm a CEO of a nonprofit healthcare system, not a large national insurance company.
I was hoping you would make.
I would also say that I believe the Attorney General has regulatory authority over nonprofits, and I think there are some additional steps that they have to take. Mostly because I was trying to copy them for some other purposes in another bill. but you know, there's some consultations required. You know, there's some people are paid too much, but as they pointed out, it doesn't end up being that broad base you need to really make a difference.
Okay, I'm going to move on to a different question. The RAND report found that there is already enough money in Oregon healthcare to pay for the universal healthcare. The job is not so much to raise more money. The task is to dispense the current funding into a single payer universal system. Wonder if anybody would want to respond to that.
Agreed. We do, you know, I've made the statement, when you're designing the taxes, you shouldn't think about who's paying. You should think about how you're distributing the savings.
Yeah,
I agree. It's who you're paying it to. You know, right now, if you're a corporation, you're paying it to an insurance company, or maybe you're self-insured and you're paying it yourself. But under this system, you'd probably be paying it to a government entity. But you know, in the end, you're just paying the money. It's a matter of to where and how to get from, once you have the system designed, you know, how to get from point A to point B in a way that makes sense for everybody.
Yeah, and I'll add to it, and I certainly add this not to say this should stop single payer, but if we did move there, and there was only one payer in Oregon, that you know, there would be a lot of health insurance companies that at least in the state of Oregon would no longer be doing business here. I'm not sure how many people they employ in the state of Oregon on the insurance side, but I'm guessing it's quite a bit, and so you would have some immediate disruption to the economy. I mean, the thought is that over time, with cheaper healthcare and more efficiency there, that'll, you know, net out positive for the economy. But it's going to affect humans in their day-to-day life to begin with, and I think that's worth at least noting.
Okay, thank you very much. I wanted to go to something more of a comment, and I wonder if we could respond to this comment. So the comment is, people can't get private health insurance under single payer. It's prohibited.
I think that's how
it depends on the system you're talking about, but yeah, I mean, in general, and as we've seen places move to single payer, I think either places, I want to say it's Canada, where you can buy a supplement. You know, there's a base plan, then you can buy a supplement. So some work that way. You know, as Mr. Boysen just pointed out, some of these evolve as the places insurance companies go. If you do replace them for their primary business, you know, sometimes they end up in supplement. Sometimes they kind of end up in other businesses, but that's kind of a challenging issue. But yeah, I mean, in general, yeah, if you're having a single payer, at least for the services that are covered by the single payer plan, then that is the only insurance.
Yeah, I know,
And
I agree with all that, and I think it just depends how the model's set up, right? I think you could have all essential services provided through the single payer, and then there can certainly be supplemental. I think the United Kingdom, some of you probably know better than me, but don't they have like a National Health Service, NHS, but then they do have private insurance on top of that that people can purchase if they would like. So I don't know if there's an absolute on any of this, but I think to get the efficiency, I think for at least the essential core services would be through a single payer.
and I would add to that, there are other countries where private insurance companies play a role, but mostly their role is just collecting premiums. They're not paying the claims.
Okay, yeah, I appreciate the different perspectives on that. So I'm wondering if you could respond to this question. How does the global budgeting of hospitals help or complicate the process of achieving population health? Talk about global budgeting and population health. I think, Doug, that was probably in response to some of the things you were saying.
Yeah, and I hear global budgeting thrown in a lot of different contexts, but
Right.
I think what the question means is what I was referencing more kind of like a population health reimbursement. And I think, if there was a way to reimburse, not just hospitals, but all sorts of providers in a certain market to be responsible for taking care of a given population, I think that would, and getting away from fee-for-service methodology, I think it would allow the provider community to use a little bit more creativity and flexibility and focus a little bit more on preventative and wellness services. So I think that would be helpful. It's complicated too, right? Because I know healthcare systems, hospitals, independent clinics get nervous about the concept because, what if you only get X amount of money and then a pandemic happens, or something unpredicted or catastrophic happens, you could quickly run out of money and you get upside down on that. So I think but I think there's ways to figure that out where there is a population health or global budget. But then you look at the acuity of the population and there could be some factors that play into that. But I think regardless of, as I said, how many payers, I think we do need to start having more of that conversation and how we get away from fee-for-service.
Yeah, go ahead, Warren.
I just might, this is actually kind of a question for Doug, but it kind of points out the idea that if you had a global budget which paid for all care, you would not have any unreimbursed care, which I believe is a very noticeable part of your budget.
It would also give hospitals and providers more stability too, right? They would know how much they're going to get going into the year, and they could plan for that, and they could plan their long-term capital needs and technology needs with that. When you're on a fee-for-service, I sometimes call it the hamster wheel. That's up and down, and a lot of things depend on how much volume you do that month, and so your revenue is up and down. And I made the joke about the pandemic, but actually, I think the pandemic has highlighted the problems with the fee-for-service model. When in the state of Oregon, hospitals shut down elective services, and in our clinics, we shut down non-emergent services. Our volumes and then hence our revenue went down drastically during that shutdown because that's all fee-for-service. And so we were worried about whether we were even going to survive as an organization at one point, and whether we had enough days cash on hand to keep paying our employees. And I think a little bit more stability and a little bit more predictability on that would be good.
I want to ask a question out loud, and then a viewer included a comment about a question that has kind of been brought up. So the question is, if single payer were to come into play, would this not result in a significant number of jobs that are being lost? And so there has already been commentary about this out loud. And so, I first want to have a little bit of a conversation about jobs lost, and then I want to share what one of the viewers stated, a comment one of the viewers stated, which is regarding the unemployment in insurance companies from single payer, that state and national single payer studies estimate that the number of new clinic jobs created is 3 times the number of jobs lost in billing and insurance. So first, could we reflect out loud on jobs lost and then the potential for the replacement of those jobs with the new clinic jobs created?
I think I would maybe question a little bit of what you said. If you save money, because 70% of the cost is labor, you're going to be affecting labor. You can't save money without affecting labor. I think every responsible bill that I've seen, both at state and national levels, has taken into account things like providing retraining or providing guaranteed retirement contributions for people who are in their 60s and maybe not likely to get their jobs. So it is one of the things that has to go into the equation. But I think most studies say that it might eat up the savings in the first year, but the savings will become more and more evident the further that you go. As far as the general economy, I mean, you think about the number of jobs that have been created in the health sector. Those people were doing something else before, and people were paying the money to do that. So presumably, if we stop paying a quarter of our household income on healthcare, we will find something else to do with that money, which is going to create new and different economies.
Thank you,
Yeah, I
Warren.
would say we're dealing with a similar issue in electrification of transportation and green energy. It, sort of as the jobs move from sort of legacy hydrocarbon systems into green energy, the skills are not identical. And so, part of all the, we do transitioning, we call it just transition planning, to make sure that there is a plan and that we're trying to catch the workers who are going that. It is a non-trivial problem because people are often not real excited about getting retrained, but it's the right thing to do, and we work hard at it when we do it.
Thank you for that comment. Any other comments about jobs lost, jobs gained? There's other comments. The more we talk, the more questions that are coming up. By the way, one of the viewers who's participating is actually a task force member who has himself been on panels such as these. And he is reminding us that almost every single payer nation allows individuals to purchase supplemental, complementary, and wraparound private insurance. So he's out there reminding us of this. So
Ed, let me just make a comment, about jobs gained. And I think, Warren is very realistic about this, but
yeah,
to kind of go back to my theme of looking at population health and community health, I would love as a society, we decide to invest more resources into what I would call like basic kind of care navigation services, wellness services, and then certainly behavioral health. I mean, I think these are all some services that have not been reimbursed very well under traditional fee-for-service environment. As a result, you don't have a lot of people providing those services. But I think if we could put more resources into that, I think we could build up a more robust infrastructure. And I think, as far as just public health, I think the pandemic has also highlighted that as a country, we've probably skinnied that down too much. We haven't put enough resources into our public health departments. And I think there are a lot of good people that are doing wonderful things, especially in our 3-county area. They probably don't have enough resources to, do everything that they could be doing to maximize health in our communities.
Yeah, Doug, I think you've struck on, you keep striking on a couple of yes. themes. No, it's mental health. It's upstream services. It's public health. It's community wellness. It's the support of addiction. Those are all super important things that really need an entire forum for discussion, without a doubt. Another Here's another interesting question. They're all frankly interesting and fascinating. If everyone is insured and we don't have enough doctors and healthcare providers in Oregon already, how will all the extra care be provided? The people who have not had care deserve it, but how can we provide it without having to add more healthcare workers? And where will those workers come from?
I think, I mean, certainly the studies that I've read is that the increase in, I mean, there will be people seeing doctors who haven't been seeing them before or haven't been seeing them often enough. But the fact that providers will be spending less of their time on billing, they'll have a ability to see more patients in a day without actually increasing their time spent on the job. So it's not obvious. I mean, there's always going to be shortages in some fields. And in some ways, a state system can address that probably more efficiently by saying, we don't have enough doctors in this area. We need to do something about that. That can be done by a single payer type system in a way that that just, let's call it private medicine, which includes nonprofit, is going to have a harder time adjusting to those things. I mean, you're actually chasing the need instead of trying to figure out how to raise revenue.
Yeah, I would say also there's some other things that are working in this direction too. If you make community college free, remember you can get certifications up to an RN level, and many of the jobs we would need through community colleges. So, and in fact, that's the cheapest and most efficient way of training a lot of people. So, you know, there's work to do. Don't get me wrong. We do tend to focus a little on the very highly skilled workforce as opposed to the low and mid-skill workforce. I'm not trying to denigrate anybody's job, but the reality is there are shorter programs that would do that, and you know, there are frankly some more efficient delivery models of healthcare too that help those people and have them practice the top of their licensure as well.
Maybe Doug has something to add to that, but I wanted to say that actually one of the things that's happening in American healthcare is we're kind of, I almost hate to use the phrase driving things down, but there is a lot of good work being done by nurse practitioners and things which maybe used to be limited to physicians. And there's lots of studies by Harvard and others that show that the care that's given by these people is in many cases better. If you have a neighborhood person who specializes in colds and flus, some evidence by Consumer Reports actually shows that the result is better care than they will get in the emergency room, where maybe that kind of repetitive attention to the minor kinds of diseases isn't existent.
Yeah, and I would agree with that, Warren. I think one of the tricks is getting all the different clinicians practicing top of license, you know, basically maximizing what they do. And certainly advanced practitioners, PAs, nurse practitioners are something that we're trying to leverage more. We have a large residency program. So these are students that are, well, they're out of medical school and they're fine tuning to be independent. And we also leverage residents in our system. I will note though, you know, that would be, if there's a concern of all this, I would be nervous if at the end of the day, we have this single payer system in Oregon and it does impact what organizations can pay to doctors, because it is still highly, highly competitive to recruit doctors, especially certain kinds of specialists into Oregon, and especially into rural Oregon. Even primary care or psychiatry are a couple of the areas that it's really challenging. I think we're lucky that we have a medical school out in, it's not Samaritans, but we partner with Comp Northwest, where Dr. Junkins works in Western University of Health Sciences. And we are all really fortunate that they have a medical school there and that we're able to partner with them. But, you know, for a lot of places in Oregon, they don't have a medical school, you know, in one of their communities. And it is really tough to recruit doctors into the state. And so we're going to have to, as a state, however we fine tune this, make sure that we continue to be competitive in how we can bring in practitioners and clinicians.
And to reinforce that, when I used Dr. Papanikolaus's assertion that there's 3 main causes for higher care, and then proposed how we could run a universal care system to address those, there's nothing in that math that I did that reduces anyone's pay. We have to be competitive. We live in the nation we live in. Maybe we could wish that pay was a little flatter like it is in other countries from bottom to top, but Oregon can't set those rules by itself.
Right. You're exactly right. Yeah, thank you.
So team, we are drawing to a close. There are a couple of questions and comments that I just wanted to call out loud. Some of them less, and I haven't been able to get to everybody. And so those of you who are writing questions, thank you so much. Some have submitted several. I've tried to move them around from different people. There was a request for Warren George's tax calculator. That email. So could you put information into the chat on how to get that? I think it was your email is what you offered, but could you?
I'm not sure that chat is available.
Okay.
Is available to viewers, but I will say my email is george@peak.org. You can just send me an email, and I'll give you a surprise package.
Perfect. A couple of other sort of quick items. There was a question about the veterans. You know, are veterans being exempt under an Oregon single payer, single pool program? And I can tell you from a task force standpoint, we're looking at, you know, veterans. There are different pools of entitlements that are being discussed. Obviously, Medicare, Medicaid. The Indian Health Service recipients, veterans, public employees, these are all groups that you know are being pulled out, discussed. The task force is looking at all Oregonians, everybody in, nobody left out. And then starting with that, you know, how do you make sure that people are getting, you know, as good of benefits, if not better than what they currently have? But you know, that the veterans have come up in terms of you know, who is in and who is out. And I'll disclose that I was active military for 3 years. And then another comment, which I thought was you know, really excellent. A viewer says, very complex to change, took Taiwan less than 9 months. Does somebody want to respond to that? I have, you know, thoughts on it, but I'm curious, you know, why the U.S. is different from Taiwan in making a change such as this.
Well, I mean, I think I would just point out that Taiwan did it nationwide. So you're correct. If the federal government decides they want to change it, then you know they can move pretty quickly. However, we in Oregon we're operating in this federal context, and so you know, we have to do a lot of Mother May I. So if we wanted to get money from, for instance, the Veterans Administration, because we were going to bring veterans into our program, well, there's no existing law for that right now. So there'd have to be a law passed in Congress to allow them to do that. So it's just, you're right. When there is a collective will to do it, it's just, we're not a sovereign in the same sense that Taiwan was, or is, I should say.
As we are really drawing to a close, I think I just have a minute. Some of the questions talked about equity. You know, not everybody has equal access or even equitable care. Every one of us has mentioned this in some regards. That's another goal to try to close these disparity gaps and to improve equity, you know, in the system. That might mean an access issue. That might mean the delivery of healthcare. There are many other questions in the chat, but I think we are reaching the end of the program, and I just wanted to publicly thank the organizers of this. This is the HCA of the Mid-Valley. Some very passionate people, not the least of which is Mike Huntington, Dr. Huntington, who is part of the organizing group for this. Wanted to thank him out loud, Karen Christensen and the others, as well as the League of Women Voters for sponsoring this conversation. Many thanks to Warren George for his presentation. I always learn a little bit when I listen to Warren. To Representative Marty Wilde. Again, it's always nice to hear this from the perspective from not only our region in Oregon, but what's happening in Salem. And then of course, Doug Boysen, who is in our community. I'd love to hear him talk about community wellness, population health. As a population public health officer myself, I think that's how we fix things. With that, we've come to the close of our program. And I again want to thank all viewers for participating, and thank you for your continued support of the healthcare conversation.